والصلاة وأتم التسليم على سيدنا محمد وعلى آله وصحبه أجمعين. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا وزدنا علما متقابلا برحمتك يا رحمن. ربي اشرح لي صدري ويسر عقدة من لساني. Brother and sister, so today inshallah we are going to discuss the management of hypertension. According to the European Society of Cardiology 2018, hypertension remains the major preventable cause of cardiovascular disease and all-cause mortality worldwide. Hypertension is considered as a risk factor for cardiovascular diseases. How we can define hypertension is a persistent elevation in the arterial blood pressure. The definition differs from guideline to another, but here I depends on the Malaysian guideline 2018. So the definition is systolic blood pressure equal or more than 140 and diastolic blood pressure more or equal to 90. So 140 over 90, beyond this range considered as hypertension. We have hypertensive crisis in which there is a very increase in the blood pressure more than 180 or the systolic diastolic 120. We have two types under hypertensive crisis. We have hypertensive emergency in which damage of organs. But in urgency, there is an elevation of the blood pressure, but without target organ damage or injury. Target organ, when we say target organ, we mean the brain, eyes, heart, kidney, and also peripheral vessels. We have, I compile all the definition in this first line. Resistant hypertension, where it's not an uncontrolled blood pressure, although the patient on 3 or 4 antihypertensives. The refractory, when the blood pressure is not well controlled, although the patient is on 5 or more medications. Also, another definition of hypertension is where the treatment of hypertension is outweigh the benefit of treatment outweigh the risk of treatment. Worldwide, is about 40% of adult population have hypertension. Almost the same in Malaysia. 1/3 of the Malaysian population have hypertension, and it was found that for each one newly diagnosed with hypertension in Malaysia, there is 3 other individuals who have hypertension but not yet diagnosed. Of course, the hypertension is the leading cause for stroke and cardiovascular diseases. Unfortunately, only about 1/3 of adults have their blood pressure control. Same also applied in Malaysia. Now moving to etiology. We need to differentiate between etiology and pathophysiology. Etiology meaning the reason that may lead to the disease. We have the hypertension is either primary or secondary, but in 90% of the cases it is primary, meaning there is no secondary cause. There is no disease lead to hypertension. It's an essential hypertension or primary hypertension. In only less than 10% of the cases, there is another disease that may lead to this hypertension. One important is drug-induced, like in case of using corticosteroid or contraceptives. They may lead to high blood pressure. This photo summarizes the risk factors. The risk factors. Okay, risk factors meaning these may lead to hypertension, but not all of these will lead to hypertension. They are only risk factor. You have to be very familiar with that because this is also a risk factor for other cardiovascular diseases. Now moving to pathophysiology, there are some genetic factors. People who have a family history of hypertension or cardiovascular diseases, they are at higher risk also to develop hypertension, in addition to environmental factors. We have neural mechanism. In patients with hypertension, there is an overactivity of sympathetic nervous system, meaning the adrenaline in these people is more active. The other one is the vascular mechanism. There is a decrease in the vasodilating substances. In our body, we have vasoconstricting substances and also vasodilating substances. Patients with hypertension, the level of vasodilating substances like nitric oxide is low, while the vasoconstricting substances like angiotensin II are high. Hormonal mechanism, natriuretic hormone. Natriuretic peptide or arterial natriuretic peptide, ANP, is a protein that have an opposite effect of aldosterone, meaning it prevents from retention of water and sodium. The second also mechanism in which the patient may develop or individual may develop hypertension is insulin resistant and hyperinsulinemia. They found that patients who have high level of insulin at higher risk to develop hypertension. Why? Insulin retained in the body sodium and also increase the calcium inside the cells. In addition, that insulin have what we call growth hormone like effect. So it increased the thickness of the vessels, which may lead also to hypertension. The most important mechanism, I believe you are familiar with that, which is renin, angiotensin, aldosterone system. How it started? Usually it started when there is a hypoperfusion from of the blood to the kidney. So the kidney will secrete renin. Renin will convert angiotensinogen, which is secreted from the liver, to angiotensin 1. 1 will be converted into 2, and 2 have a vasoconstrictive effect. In addition, also it activates aldosterone, which increases the sodium and water retention. So this is one of the target of the treatment. What are the clinical presentation of hypertension? Most likely there are no symptoms in patient symptoms in patient with presentation. Signs meaning, of course, there is high blood pressure because this is by definition. But because of that, it is named the silent killer. This is the classification according to the Malaysian guidelines, CPG 2018. So we have normal. The normal one is, or optimal, below 120/80. This is the optimal. Normal, below 130 and 85. At risk above that. Consider as hypertension, as we mentioned in the definition, which is either equal or above 140/90. Stage 2, 160/100. Stage 3, severe. This is most likely hypertensive crisis. In some patients, there is isolated systolic hypertension. Only the systolic hypertension is high. Most likely, we'll find it in elderly patients, but still the treatment is the same. A very important point is how we measure the blood pressure. It was found, there is a study found that 9 out of 10 medical students don't exactly do or follow the steps, the ideal steps to measure the blood pressure. So it's important to know all the uh, instructions. I'm just taking the attendance now. So how to measure the blood pressure. These photos summarize what are the rules in measuring blood pressure. The back should be supported and also the arm at the level of the heart, and it's recommended that the patient does not talk while you are taking the blood pressure, and the feet are not crossed. The patient didn't smoke for the last uh, 30 minutes, no smoking, coffee, or exercise for the last 30 minutes, and also empty bladder. The patient is relaxed 3 to 5 minutes. So if you are at the pharmacy and somebody asks you to measure the blood pressure, you have to ask him to rest for about 5 minutes, and after that you may measure the blood pressure. Of course, you cannot depend on one reading to diagnose hypertension. Not you, of course, diagnosis is the job of physician, not the pharmacist. But of course, you can refer any patient to physician if you see that the patient has a high blood pressure. So you need to take more than one reading, usually 2 to 3 reading per day for 7 days, taking the average, and then after that you may say this patient having now hypertension. This one of the method that is no longer recommended. It's to put ambulatory blood pressure monitor, in which this will be on the patient arm for 24 hours. So it continuously observe the blood pressure. But it's not needed. Usually frequent reading several times per day are enough instead of continuous reading. So this is different types of hypertensions. Hypertensions usually they differentiate between the reading at the office, meaning in the clinic, and also at home. Some patients they have only hypertension when or the blood pressure is high only if they are at the clinic. They called it white coat hypertension or white coat reaction. If you measure the blood pressure at home, it is normal. Once the patient at the office in the clinic, the patient may be stressed, so because of that, the blood pressure is high. And another opposite one is the masked hypertension, in which in the office there is no hypertension, but at home the patient is hypertensive. This is what I mentioned about the complication is another condition that happened while the course of the current disease. So while the patient having hypertension also may develop one of these complications to the heart, brain, kidney, eye, and also peripheral vessels. The most important common, of course, myocardial infarction, coronary artery disease in general, stroke for the brain, in addition to renal impairment. Okay, so this is the risk stratification. Now you need to consider not only the blood pressure reading. Okay, the new guidelines, these guidelines saying that you shouldn't solely depend on the reading of blood pressure. You have to take into consideration other risk factors using this table. If the patient has low or intermediate risk factors for cardiovascular diseases, so usually lifestyle changing is enough. If the patient having medium, high, or very high risk for cardiovascular diseases, so you need to start with pharmacotherapy, as stated here. Risk factor or major cardiovascular event. These links will take you to a tool that assesses the cardiovascular disease risk for the next 10 years of the patient. than 10%, meaning we have a possibility more than 10% that this patient will develop a cardiovascular disease in the next 10 years. So this considered as medium. If it's, for example, the risk is more than 30%, so we are about 30% sure that this patient within the next 10 years will develop cardiovascular disease. It will consider as very high. Now moving to the management of hypertension. Of course, as we mentioned yesterday, you need to put your goals. Put goals and then try to achieve your goals. Of course, to reduce the target organ damage, so meaning to prevent complication. And of course, you have to maintain a normal blood pressure. Generally speaking, it's below 140/90. In very elderly patients, it's not prudent to target low blood pressure. As mentioned yesterday also, because the risk may outweigh the benefit of giving several medication or aggressive treatment in elderly patients. In very high risk patient, as mentioned, meaning the cardiovascular risk for in the next 10 years, more than 20. So it's better to target below 130/80. First, starting with the non-pharmacological management. I believe you all familiar with that. How you educate the patient to change the lifestyle. Weight reduction, of course, stop smoking, change to a healthy diet. There is a diet which is dietary approaches to stop hypertension, called it DASH plan. This is the summary of DASH plan, in which they depends more on vegetables and also fruits to less extent, reducing the consumption of fats, especially saturated fat. I will give you the full instruction for the DASH diet. I will upload here and on iTally. They found that once the patient started to change their lifestyle, this will significantly reduce the blood pressure. Okay, here the details for each non-pharmacological approach. If the patient reduce weight, start a healthy diet, this is what the result in reducing the blood pressure by 5 millimeter mercury or 11, depends on the lifestyle change. Another one is reducing alcohol consumption. Why I put it here in red? Because usually you read in any guidelines, just reduce the consumption of alcohol. They don't say just stop. But in fact, there is a large study he conducted in 2016, which is involved 195 countries, and they found that there is no safe amount of alcohol. So the safe amount is 0 for all-cause mortality. So it's recommended to encourage the patient to stop alcohol. Now moving to pharmacological therapy. The selection of drug depends on the patient condition, whether the patient have any other diseases or not. This is very essential to know whether the patient have other comorbidity or what we call compelling indication. Compelling indication is another disease that the patient has that require us to give a specific medication. This is important. Ultimately, the attainment of target PP in many cases may be more important than the antihypertensive agent used. For example, for diabetic patients, AC inhibitor is the first choice. But if you found any patients come to your pharmacy or clinic and their blood pressure is well controlled by CCP, Does it mean that you need to change from CCB because this is not the first line in diabetic patient, change to ACE inhibitors? Of course not, because controlling the blood pressure is more important than the medication you are using. So if it isn't broken, don't fix it. If it's well controlled, whatever the medication is used, that's fine. Why principle recommend treatment with a drug taken only once daily? This to increase the adherence of patient to medications. This is again to remind you about the treatment, the strategy of treatment. Again, we don't depend only on blood pressure reading. You need to consider other risk factors. Now we will start with the classes we use to treat hypertension. We will go one by one, starting from first line therapy, second line, and maybe third line therapy. One of the first line options are diuretics, especially thiazide and thiazide-like diuretics. They are preferred usually also in elderly patients because they have less side effects compared with others. The common side effect of thiazide diuretics are they may reduce the sodium level, potassium level, but on the other hand also they may increase the calcium level, uric acid level, and also may increase the blood glucose level. The problem with thiazide, they are not effective in patients with advanced renal failure because their action, their mechanism of action, by decreasing the amount of fluid in the body by urination. But if there is a problem, a significant problem in the kidney, so giving the diuretics will not give an effect. So it's not effective in patients with creatinine clearance below 30. The most common or the most commonly used medications are hydrochlorothiazide. Do you, as a student, do you need to remember all the medication with doses? I ask you, it's required to at least remember one. So choose one from the group, from the drug class, and you have to know the medications dose, starting dose, and also maintenance dose. Another type of diuretics are potassium-sparing diuretics. Amiloride and considered as weak antihypertensive, and we don't use them as first line. Potassium-sparing diuretics, we don't use them as first line. First line is thiazide or thiazide-like diuretics. We combine this medication or this potassium sparing with the normal diuretics in order just to reduce the side effects of hyponatremia. Aldosterone antagonists like spironolactone and eplerenone, we use them not only for hypertension. We will see that they are indicated for patients with heart failure. They are not recommended, aldosterone are not recommended to be used in patients with creatinine clearance below 50. Of course, one of the expected side effects is hyperkalemia because they are potassium sparing. So I said we combine to reduce the excretion of potassium into hyperkalemia. Next. What happened? Okay. So again, choose one. Spironolactone, for example, you have to know we started with 25, or maybe in elderly even half of the dose, 25 milligram, and then we continue up to 100 or 200 milligram per day. So moving to another first line treatment, calcium channel blockers. We have two subgroups of calcium channel blocker, non-dihydropyridine and dihydropyridine. Non-dihydropyridine, verapamil, and also diltiazem. The mechanism of action, their mechanism of action on the heart. So they reduce the inotropic effect. So they have negative inotropic effect. So verapamil works mainly on the heart. Diltiazem have a mixed effect on the heart and also on the vessels. While dihydropyridine medication like amlodipine, folidipine, they mainly target the receptor in the vessels. As they reduce as they have negative chronotropic and also negative inotropic effects, it's not recommended to be used in patients with reduced ejection fraction. The most common side effects for this medication are constipation and also ankle edema with verapamil. Should be used with caution in patients with heart rate 60. Why I put this asterisk? Because some reference consider it as contraindication, not only caution. Some references consider it as contraindication, meaning shouldn't be used with heart rate below 60. Of course, the combination of beta blocker with non-dihydro, only non-dihydro. Please don't get confused. Only non-dihydropyridine, verapamil, diltiazem are not recommended to be combined with beta blocker. Okay, they are not first line. The first line is the second subgroup, which is dihydropyridine. So they are first line antihypertensive agents. They don't decrease the AV node conductions, meaning they don't affect the heart contractility. One of the common side effects is reflex tachycardia, but usually the body will compensate, meaning this starting only at the beginning, and then the patient will not suffer from reflex tachycardia. Contraindication, one of the contraindication is unstable angina. If the patient comes to the hospital with unstable angina, dihydropyridine shouldn't be used. Other side effects are flushing and palpitation. This is the list. You have to, again, choose one from the dihydropyridine class and also one from non-dihydropyridine to remember the doses. The most common used medication is amlodipine. We start with 5 mg and can be increased to up to 20 mg per day. 10 mg per day. The third class, in which are considered as first-line options for patients with hypertension, are angiotensin converting enzyme inhibitor or ACE inhibitors. They have actually several mechanisms of action by which they reduce the blood pressure, and also not only the blood pressure, they reduce the cardiovascular diseases. So it found that they reduced the cardiovascular risk, mortality, and morbidity. Now the study does not only depends on the effectiveness of medication by reducing the blood pressure, also it should have positive effect in terms of the mortality and also morbidity. So not if the medication only reduces the blood pressure but have no long effect on the mortality and morbidity, it's not recommended as first line. But ACE inhibitors, CCP, they are it's confirmed that they have positive effect in terms of mortality and morbidity. But this is common in US and other countries. It's not recommended to use ACE inhibitors in black patients because black patients, the renin levels is by are low. So meaning the renin, angiotensin, aldosterone system is not the major contributor for hypertension in this population. So this is not the main reason for hypertension in this population. So it's better not to target this pathway. Okay. So we will give them other medication. For AC inhibitor, we start with low doses because it's expected to cause postural hypotension. Contraindication in patients with hyperkalemia. It's well known that the AC inhibitors may lead to increasing potassium level. The most common side effects are dry cough, okay, in addition to angioedema. Should we stop? Okay, if the patient cannot tolerate the dry cough, we need to stop the AC inhibitor and change usually to uh, ARB, angiotensin receptor blockers. What about renal insufficiency? If you started AC inhibitors and it decreased or increased the level of creatinine in the blood more than 30% of the baseline, we need to consider stopping AC inhibitors. This is very important point and a tricky point for the healthcare professionals. Some believe, which is of course this is a misunderstanding, that AC inhibitor shouldn't be used in patients with renal impairment. It's not correct. It can be used even in patients with advanced CKD, but with reduced dose. The only problem that shouldn't be used if the patient has, uh, uh, let's see again here, if the patient have bilateral renal artery stenosis. What does it mean? If the patient have any problem with the efferent artery, as you can see from the figure, if there is bilateral, meaning both kidneys have this problem, only in this case consider as contraindication. Otherwise, you can use unless it again causes to increase the creatinine level more than 30% of the guideline. There is a common drug-drug interaction between AC inhibitors and also NSAID. I want you to find out why NSAID and AC inhibitors are not recommended to be used together, and what is the mechanism of this drug-drug interaction. Here in italic, the combination of AC inhibitor and CCB usually considered as one of the best combination, okay, to reduce the cardiovascular risks. Again, choose one to memorize. The other group also consider as an alternative usually for AC inhibitor is angiotensin II receptor blockers. Unlike AC inhibitors, ARB don't block bradykinin. Bradykinin breakdown usually happen in normal individuals, but AC inhibitors, when it's given, they block the bradykinin breakdown. This leads to accumulation of bradykinin. I'm talking about AC inhibitors. And accumulation of bradykinin in the body will lead to dry cough. In contrary, angiotensin II receptor blockers don't block bradykinin breakdown, meaning they don't have side effects of dry cough. Again, they are an alternative for AC inhibitors. Can we combine AC inhibitors with ARB? Generally, it's not recommended. Okay. They have the same side effect except for the dry cough, and also contraindication same as AC inhibitor, like patient with, as I mentioned, bilateral renal artery stenosis and in pregnancy. AC inhibitors are considered as class X, meaning must not and also must not be used. They are contraindication in patients in pregnant women. And this is the available ARBs. So to summarize, before moving to other classes, we have three classes considered as the first line therapy. Thiazide and thiazide-like diuretics, CCP, dihydropyridine CCP, and in addition to AC inhibitors. Anyone, you can start with any one. We will see which one we need to choose depends on the patient comorbidities. Now moving to second or third line options in the treatment of hypertension. Alixurine is a direct renin inhibitor. So it does not affect the angiotensin, it affects the renin from the beginning of the cycle. It's an alternative, but actually there are so far no enough study support the use of aliskiren as a first line option. And of course shouldn't be combined with AC inhibitor or ARB, especially in patients with DM or creatinine clearance below 60. Also, aliskiren shouldn't be used in patients with creatinine clearance below 30. Another common class of medication that are used in patients with hypertension are beta blockers. The exact mechanism of action of beta blocker of reducing blood pressure is not fully understood. But they have negative inotropic and chronotropic action, meaning they affect the heart, contractility and conductivity. They are recommended in patients with arrhythmia, coronary artery disease, after myocardial infarction, and patients with heart failure. So beta blocker are not the first line option unless the patient have one of these comorbidities: coronary artery disease, including myocardial infarction, arrhythmia, and also heart failure. There are some properties of the beta blocker which differences between the members of this class. We have cardioselectivity. When we say cardioselective, meaning this medication does not cause bronchospasm. This is important in patients with asthma or COPD. However, the selectivity is dose dependent. If you give the patient selective beta blocker with higher doses, this may become non-selective or have non-selectivity effect. Some beta blocker, they have membrane stabilization activity. This is important in patients with arrhythmia. So this medication like propranolol, betaxolol, and carvedilol can be used in patients with arrhythmia because they affect the membrane of the cells that are responsible for transportation of the ions. Intrinsic sympathomimetic activity. Some beta blockers have partial agonist effect. So when first induced, it may lead to worsening the condition because they have ISA property. But later on, it will decrease, for example, the heart rate because it will become antagonist. The last one is vasodilation. Some beta blockers have also vasodilation activity, either by mixed effect on alpha receptor in addition to their effect on beta receptor, or because they increase the nitric oxide in the vessels. Here we summarize the beta blockers with their effect. Okay, pay attention that one of these features does not necessarily counteract the other feature. Meaning, if the medication is selective, it does not mean that necessarily it does not have ISA effect. It could have ISA effect or not. Okay, if the medication have vasodilation effect, also it may have ISA effect or not. So what you need to know, okay, just to simplify, you need to know, of course, you need to remember selective and non-selective, of course, and those who with alpha antagonist effect also. So you have to know that propranolol, for example, is non-selective, and also that carvedilol having alpha blocking effect. Contraindication shouldn't be used in patients with hypovolemic shock, cardiogenic shock, and transmetal angina and uncontrolled decompensated heart failure. For patients with asthma and COPD, can we use beta blocker? Yes, assuming that the asthma and COPD are well controlled. If they are well controlled, you can use selective, of course, only selective. But if the patient currently having an exacerbation of asthma, this means that the asthma is not well controlled. In this case, you shouldn't give the patient even selective beta blocker shouldn't be used. But in general, if the patient has asthma or COPD, but this condition is well controlled with inhaler, so you can use selective beta blocker. Cautions, it should be used with caution in patients with heart rate below 60. Below 50, it's not recommended to be used. It's considered as contraindication also in some references. The important point, also beta blocker have several side effects, especially in elderly, okay? And we may differentiate between lipophilic and hydrophilic agent. Lipophilic meaning they can cross the barriers to the brain, and it may causes dizziness, nightmares, especially for elderly. One of the common side effects also sexual dysfunction in men. Beta blocker shouldn't be stopped abruptly. Otherwise, you put the patient on risk for myocardial infarction, unstable angina, or even death. So, beta blocker shouldn't be stopped abruptly. Should be gradually stopped. Why? If you stop abruptly, they are receptor antagonists. If you stop abruptly, meaning all receptors are now free to receive the adrenaline, the internal adrenaline. And this may lead to myocardial infarction and even death. This is a summary of the beta blocker. Again, you have to choose at least one agent, selective agent, non-selective agent, and agent with a mixed effect for alpha and beta receptors. Okay, moving to alpha receptor blockers. Do you have any questions so far?
I think
Any
so far
question?
no.
Okay, fine. Also at the end of the class, okay, inshallah, I'll ask if there is any question. Now, alpha receptor blockers, you are also, I think you know this agent, prazosin, doxazosin, and tirazosin. They affect the alpha receptor in the vessels, leading to vasodilation. Of course, they are not the first line because they have inferior effect. So they don't have equal effect compared with other agents. So generally are considered as second line, third line, or fourth line. But when it should be considered as first line in patients with benign prostate hyperplasia. So we give these medications as for dual indication, for hypertension and also for BPH. Common side effect of alpha receptor blockers are the postural hypotension. Because of that, it's recommended to start at bedtime. Then after that, after a few days, few weeks, can be used at bedtime or also at morning to them. This is an example of a question yesterday. One of the sister asked whether is it possible that the medication cause side effect and then after that it will reduce spontaneously. Yes, the body can compensate, can adapt the medication. So it can cause at the beginning postural hypertension, but after that the patients can tolerate these kind of side effects. In general, alpha blocker are not recommended to be used in elderly patients above 65 years old, according to Pear's criteria, which is criteria for elderly patients. Alpha blocker are not recommended unless the patient have benign prostate hyperplasia. Take one again, pick one, and remember doxycycline is easy to remember because 1 milligram OD. Starting dose, you can consider up to 16 milligram daily. I think the last class of medication, centrally acting agents. No, not them. No, I think we have another class also. Centrally acting that affects the centers in the central CNS. They decrease the heart rate, cardiac output, and also total peripheral resistance and plasma renin activity. They are not, again, not a recommended option, rare choice, and also they shouldn't be stopped abruptly. When we can consider these, either again if the patient using 3 medication but still their blood pressure is not well controlled, or in a pregnant patient, alpha methyl dopa is the first option. Again, also this may lead to orthostatic or postural hypotension. Methyl dopa rarely can cause hepatitis, so it should be considered as a caution in patients with hepatic impairment. So we have clonidine, moxonidine, and methyl dopa. Moxonidine has been shown to increase mortality in patients with heart failure, so it's contraindicated in heart failure. Anyhow, this agent is rarely used. I'm not sure whether it's also available in Malaysia or not. I think this is the last class, is the direct arterial vasodilator. Most of what we mentioned are vasodilator for veins. Okay, now this for the artery, hydralazine and minoxidil. They direct arterial smooth muscle relaxation, usually used in resistant hypertension. Those who are 3 or 4 medication but not respond. We have to start with the first option, beta, in addition to beta blocker, and then we may consider this kind of medication. Minoxidil also can be considered for refractory. Refractory differentiate between refractory and resistant hypertension. Refractory when using 5 or more medication, but still the blood pressure is not well controlled. This is how we implement the therapy. Okay, this is the algorithm according to the Malaysian guideline 2018. So you will measure the blood pressure again, not one reading, as you can read here, repeated measurement. And then if you find that it's above 160 or 100, this is considered stage 2. In stage 2, consider using a combination. Except for elderly patients, we start with monotherapy. Now, on the left side, you can see if the blood pressure between 130 to below 160 or 80 to 100. You need to assess also other risk factors for cardiovascular disease, the table I stated in previous slide. If the patient have low or intermediate risk factors, so you may repeat the measurement after 3 or 6 months, in addition to recommendation on lifestyle changing. If you found after the second visit that the blood pressure is 140 over 90, so consider treatment. If it's still below 140 and 90, only by lifestyle changing, so you just follow up without pharmacotherapeutic treatment. So to summarize also, in stage 1 hypertension, you start with monotherapy. Which monotherapy you need to start? Again, diuretics, thiazide diuretics, CCP, dihydropyridine CCP, and AC inhibitors. One of them you can start with. if not controlled within 6 months. This is also a repeated question by the students. So if the medication is unable to control blood pressure, should we increase the dose or add on another medication? There is no definite answer. It depends on the agent. Some study depends on the medication. For example, beta blocker. Is it okay to give the maximum dose of beta blocker or combine CCB with beta blocker? No, it's better to combine. So it depends on the condition and also on the agent. So you either increase the dose, switch to another class, meaning change or add on another medication. In case of stage 2, start with combination therapy. Combination therapy also can be considered as first line in high risk stage 1 hypertension. Even if the patient at stage 1, meaning 140 over 90, but with other risk factors that classify this patient as high risk patient, so we may consider giving combination therapy. The preferred one is the single pill combination. Now the pharmaceutical companies, they produce one pill that contains more than one active ingredients, like thiazide with CCP, thiazide with AC inhibitor, amlodipine with, for example, captopril, one pill. This increases the adherence of the patient to medication, easier for the patient to take the medication. This is the recommended combination based on the outcome trial. So there are studies, they found these combinations are recommended. You can use any of these combinations. Now this is a compelling indication, depends on the comorbidity. It's very important to be familiar with this, okay? The first one is diabetes, which is you can see the more pluses sign, meaning it's the higher recommendation. It's recommended, highly recommended. So in diabetes mellitus, for example, you can see that AC inhibitors is number one. Coronary heart rate disease, AC inhibitor in addition to a beta blocker. Asthma, you can see a minus sign on beta blocker, meaning it's not recommended to use beta blocker. Peripheral vascular disease, AC inhibitors. Renal impairment, AC inhibitors. Again, this is emphasize and confirm what I mentioned in AC inhibitor. AC inhibitors have a renal protective effect. So in patients with diabetes and with renal impairment, it's recommended to use AC inhibitors. Unless, again, it increases the creatinine level more than 30% of the baseline. In special populations, diuretics, AC inhibitor, CCP, and ARBs considered as first option. Usually we start in elderly patients, we start with monotherapy and low doses. We start with low doses just to avoid the side effect. And older adults, okay, should we start treatment if they have only stage 1? Okay, again, it depends not only on the blood pressure reading and also with other risk factors. So this statement, treat the older adult when systolic blood pressure is more than 160, assuming that they don't have any other risk factor. If they have other risk factor, you need to stratify the patient according to their risk factor for cardiovascular diseases. So this is the treatment for systolic blood pressure target in older adult more than 80 years. It's below 150. 65 to 80 is like other individual below 140. If there are multiple comorbidity, functional and cognitive impairment, consider less strict target. Limit number of antihypertensive agents. These patients, we have low expectancy of their life. They have multiple comorbidities, so they are not very strict in the target. And we try to reduce the number of medication instead of giving too many medication and increase the possibility for drug-drug interaction and also adverse drug reactions. In children and adolescents, these usually have secondary hypertension due to other diseases. However, the non-pharmacological treatment is the first option if still the blood pressure is not well controlled in these children and adolescents. We may consider the first option, same first option, ACE inhibitors, ARBs, CCP, and thiazide in addition to beta blocker. Should take into consideration if you use ACE inhibitor or ARB for female who are sexually active, because if they get pregnant, ACE inhibitors and ARBs, they have significant teratogenic effect on the fetus. So it's not recommended to be used in a female at the age of pregnancy, assuming they are sexually active. In pregnant women, as we mentioned, methyl dopa is the first option. Now, there are increasing evidence that labetalol is also effective and safe in pregnant women, in addition to nifedipine. Now, how you evaluate your treatment. Okay, of course, you have to keep monitoring blood pressure, but it's not enough. You have to evaluate the global risk factors, and the uh, the possibility for having cardiovascular diseases. So usually we need to monitor blood pressure and also renal profile and other parameters related to cardiovascular diseases. And monitor as in rate, monitor patient for signs and symptoms of progressive target organ disease, as I mentioned, renal profile, and also regular eye checking, especially for elderly patients. So by that, we finish with the chronic hypertension. Only a few slides for hypertensive urgency. We said that we have two subclasses, hypertensive emergency and also hypertensive urgency. Urgency when there is no target damage, target organ damage. First, you have to rule out medication-induced hypertension. There is one approach, non-pharmacological approach, which is quite important for this patient. Just put this patient in a quiet room and let him relax for about 2 hours. This may reduce the blood pressure by 20 millimeter mercury. Tilt the head of the bed 50 degree, okay, like this, and also verify blood pressure after 30 minutes. In some patients, you don't need to give medication. Other patients, you need to give. Usually, if the patient having hypertension and he is on medication, you just continue with the old medication by increasing the doses. So if the patient is with chronic antihypertensive, check the patient compliance, increase the dose, and you may add new agent. In patients who are this is the first time come to the hospital with hypertensive urgency, you have these three medications. Why we choose this medication? Because they have fast onset of actions. Captopril you have to memorize. Yes, captopril, nifedipine, and labetalol. These three medication should be considered. Okay. Short-acting oral. In case of urgency, you don't need IV. But we will see in emergency, you need IV treatment. So oral medication. Another important thing, you shouldn't rapidly decrease the blood pressure. So initial treatment should aim of reduction of 25% of the baseline. If the patient come to the hospital with systolic blood pressure 200, you shouldn't suddenly drop it to 130 because you put the patient on the risk of hypoperfusion, which is very critical and also dangerous. So you have to gradually reduce the blood pressure. The emergency, there is an organ damage. Organ damage either now this is the first time diagnosed with renal impairment, or there is a progression of medical condition, meaning the patient having heart failure, for example, but come to the hospital with hypertensive emergency and decompensated heart failure, meaning the condition worsened. So in this case, consider as emergency. This goal, one time I put this question in the final exam. Unfortunately, just very few students were able to answer this question. Give me the goals of treatment in patient with hypertensive emergency. You have to list these 3 points. First, we'll start with to reduce 25% within minutes to hour, and then until 160 over 100 within next 2 to 6 hours, and then you will target the target blood pressure after 24 to 48 hours. Usually you need IV therapy. Sodium nitroprusside is the most recommended. You can choose any one of those and use it as IV. I think that's all from my side. A lot of information, as I mentioned, because this is important topic, hypertension, but I try to highlight the most important point. Please keep checking your relatives, especially those at risk for hypertension. Check them regularly, your father, your mother, parents, relatives. You have to have a monitor, blood pressure monitor at home, and you measure, record, and this may prevent complication, because unfortunately most of the patients will diagnosed with hypertension only if they come to the hospital with complication like cardiac attack, stroke, or other complications. So that's all. If you have any question, please feel free to write or just speak. Any question, brother and sister? Okay. If not, that's all from my side. Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh.
Thank you.
Thank you, Doctor.
Welcome.
Thank you, Rajat.